Good afternoon, everybody. Thank you all for joining us this afternoon for the third iteration of the CPOP-MAPTA webinar series focused on the confluence of the opioid epidemic and the COVID-19 pandemic. We're pleased to see a robust turnout for this really important dialogue. Over the next 60 minutes, we'll focus on current efforts to improve access and availability of naloxone to address substance use disorders and overdose reversal during COVID-19. For additional information on the entire series, please visit cpoponline.org or reach out to myself, Matthew Rubin. A few housekeeping items here at the outset that we'd like to cover. For the best viewing experience, we recommend closing any programs or browser sessions running in the background. Since webinars are bandwidth intensive, closing any unnecessary browser tabs will help to conserve your bandwidth. If you're experiencing any technical difficulties, please visit the webcast help guide by clicking on the question mark icon near the bottom of your screen, or reference the technical tips available. These resources cover the common technical questions that might arise at any point during today's webinar. The webinar console you're viewing can certainly be customized. You can minimize, resize, or move any of the open windows. At the bottom of the console are multiple application icons. If you have a question during the webinar, you can click on the Q&A icon to submit your question to the presenters. We will try to answer these during the webcast, but if we do run out of time, your question will be addressed via email. We'll do our best to address as many questions as we can within the next 60 minutes. I'd also like to call attention to the resource list located on the left-hand side of your screen. There you can download a copy of the presentation slides and access additional resources. We're pleased to be joined today by a longstanding leader in the fight against the opioid epidemic and somebody who will help shepherd us through today's session. I'm pleased to turn the call over now to CPOP co-convener and MAPTA chairwoman, Congresswoman Mary Bono. Congresswoman Bono has been a national leader on confronting prescription drug abuse since her days in Congress and has helped lead CPOP since 2014. Now, I'm pleased to turn the call over to Mary.
Thank you, Matt, and thank you to all who are participating in this webinar today. We have a tremendous group of speakers on this key topic, and we're eager to launch right in. As many of you may know, this is now the third in a series of 4 webinars diving deep into the impacts and ongoing policy initiatives related to the confluence of the opioid epidemic and the global COVID-19 pandemic. Many of the responses have hit at the very core of some long-standing CPOP and MAPTA priorities. So CPOP and MAPTA are partnering on this webinar series to promote important dialogue around preventing opioid abuse and overdose. We've noted this in our previous sessions, but it's important to underscore its importance here. According to recent data highlighted in the Washington Post back in July, opioid-related overdose deaths have skyrocketed since the beginning of the pandemic. And this comes on top of new CDC data demonstrating the 4.8% rise in overdose deaths in 2019. Which sadly erases the one-year decline that occurred in 2018. CPOP, the Collaborative for Effective Prescription Opioid Policies, was formed more than 5 years ago to develop, disseminate, and advocate for balanced solutions to this crisis. With more than 80 participating organizations from all sectors, CPOP remains focused on this mission. Mothers Against Prescription Drug Abuse is a growing grassroots movement among families who have resolved turn their experiences into positive change with loved ones, as well as across society. Together, CPOP and MAPTA bring enormous reach and expertise to these challenges. Following up on our prior 2 sessions on digital health and telemedicine, as well as medication-assisted treatment, we'll now focus today on the importance of policies to expand access and availability to overdose reversal medications, particularly during the pandemic. We're thrilled to have representatives from Capitol Hill, the White House Office of National Drug Control Policy, and the FDA on the line today to discuss their ongoing efforts within this space. As one component of the epidemic response, improving access, awareness, and availability of naloxone is a critical component to combating the opioid epidemic. CPOP and MAPTA are both highly encouraged by efforts to date to strengthen and improve distribution to patients and family members, and we recognize the additional opportunities that exist to accomplish these goals. It is critical that we continue to improve availability and accessibility to overdose reversal medications. For individuals at high risk of an overdose, as well as those who may encounter others who are at risk. Through more transparent dialogue, improved access, and state-based co-prescribing alongside high-risk opioid prescriptions, we are able to change the dynamic and work towards reducing overdose deaths and ensuring more individuals with opioid use disorders are able to seek the care that they need. The need for such interventions is only further underscored by the impacts of the current pandemic and the shift of healthcare and daily life into the home. So with that brief introduction, it's now my distinct pleasure to introduce my friend and today's first speaker, United States Ohio's 14th District, a lifelong Ohioan. Joyce served 4 terms in the U.S. Congress. He sits on the House Committee on Appropriations. Throughout his time in Congress, Representative Joyce has remained a steadfast leader in fight against the opioid epidemic, and he's a member of the bipartisan opioid task force. We're thrilled that he is able to join us this afternoon to discuss ongoing efforts on the Hill, naloxone access and utilization, particularly during the pandemic. So Congressman Joyce, welcome. I think we were trying to get together last month. I'm sorry it didn't happen, but I'm really glad you're on the phone with us today. So we appreciate your leadership on these issues, and we look forward to hearing from you today on this very important set of issues. So Dave, I'm yielding to you.
Well, thank you for those kind words, Mary, and thank you for inviting me to participate in this webinar today on an important and timely subject. As you all know, the opioid crisis has been plaguing communities across America for decades, with opioid-related overdose deaths more than quadrupling since 1999. But since I've been in Congress, I've seen tremendous bipartisan support for solutions that will help end this crisis. Over the past several years, I've been proud to see Congress come together to tackle not only the trafficking of lethal illicit opioids like fentanyl, but also work to advance recovery and treatment efforts. In 2018, those efforts resulted in our nation's first decline in drug overdose deaths in nearly 30 years. Unfortunately, we are currently at risk of seeing some of that progress made slip away. Efforts to prevent opioid abuse and assist with recovery from addiction are especially difficult during this period of social isolation and heightened anxiety. Many community health centers and other opioid abuse treatment providers have seen their revenues decline sharply, limiting their ability to operate at full strength and serve the individuals who rely on their support. I'm also concerned that the current conditions have limited access to opioid antagonists like naloxone. As this group knows, getting naloxone into the hands of individuals or family members of individuals who are at risk of an overdose is a crucial life-saving effort. I expressed these concerns in a letter to the President, which I sent back in May, as I urge administration officials to maintain their focus and commitment to combating the opioid crisis. The CARES Act, which my colleagues and I passed back in March in response to the ongoing pandemic, provided an additional $425 million for the Substance Abuse and Mental Health Services Administration in order to address potential rises in mental health and substance abuse disorders. This funding included $250 million for community behavioral health clinics and $100 million for emergency response grants, which provide flexible support to counter mental health and substance abuse disorders. Based on feedback from SAMHSA, I'm glad to report that this supplemental funding has gone a long way, particularly in ensuring naloxone is available to those who need it. As Congress debates another coronavirus stimulus package, I'm hopeful that we can provide more of those vital resources. Over the coming months, I'll continue to focus my colleagues in Congress and the administration on the efforts to push out naloxone. While providing financial resources is important, we can also meet this goal by encouraging the co-prescription of naloxone to patients with opioid prescriptions and working to reduce the stigma surrounding addiction that might prevent people from carrying naloxone. Our work in battling addiction is far from over, and promoting access to opioid antagonists is an important piece of that work. Thank you again for the opportunity to speak to all of you today, and I look forward to hearing from the rest of the distinguished speakers on this important topic.
Thank you, Congressman Joyce, for your remarks and for your continued efforts to help address access to overdose reversal medications, particularly during the pandemic. With overdose rates on the rise, quick, impactful policy changes can literally be the difference between life and death. We look forward to working with you in the months ahead. We thank you for your leadership, and you're well known for all the great work you're doing on the Hill, so thank you very much. So we're now thrilled to turn from the Hill to the White House and to the Office of National Drug Control Policy. A longtime ally to CPOP, ONDCP sits within the Executive Office of the President and works to reduce drug use nationwide through development, implementation, and assessment of U.S. policy. We are pleased that ONDCP Assistant Director Kemp Chester has joined us this afternoon. Kemp is the Associate Director of the White House Office of National Drug Control Policy and the Chief of its National Opioids and Synthetics Coordination Group. So following a distinguished 27-year career as a U.S. Army officer, Kemp leads interagency efforts to reduce the availability of heroin, fentanyl, and synthetic drugs in the U.S. by disrupting its global supply chain. Kemp leads the interagency team of subject matter experts and works closely with the White House and the National Security Council to manage a network of partnerships across the federal government, as well as our international partners, who also focus on the illicit opioid crisis and synthetic drug issues. So we're absolutely thrilled that he's able to join, and we'll now turn the webinar over to Kemp. Kemp, thank you for being here. We look forward to your remarks.
Great. Thank you so much. Could I get I believe it's slide number 6, please, which I think is my first slide. And first, I'd like to thank you, Mary, number one, for all of the work that you've done on these issues for so many years and for your leadership. And I very much appreciate that. And I appreciate you and the members of CPOP and MADPA for inviting me here today to spend just a couple minutes with you. I really appreciate it. I know many of you have known Dr. Cece Spitznatz, who's been involved as an ex officio member of CPOP since its inception. And most of you know my agency, but let me take just a quick 30 seconds and say a few words about what we do. So the Office of National Drug Control Policy here in the White House was created by the Congress in 1988. We really do three things. First, we make policy. So we develop the President's National Drug Control Strategy and some associated plans and strategies as needed. And so, for example, last year we published the National Treatment Plan, which was a requirement under the Support Act. So we are the locus of policymaking on drug policy issues here for the federal government. Second, we coordinate the interagency's implementation of those policies. And this is not only across the federal government, but also with our state, local, and tribal partners as well, who are a very important part of all of our efforts. And then third, we ensure that through our budget oversight and authority, that all of the federal drug control agencies have the funding necessary to carry out the goals and objectives of the National Drug Control Strategy so that they have the resources to advance the administration's priorities, not only across the federal government, but across the country as well. Internally, we're divided into two coordination groups. So I have the Opioids and Synthetics Coordination Group, and then my colleague, Eric Talbot, has the Cocaine Coordination Group that also includes marijuana. And I think the important thing about this is that within our coordination groups, we also have our public health, our education, prevention, and treatment are fully integrated into those coordination groups because those are the engines that drive policymaking. And what we can do is we can take all of those national security and law enforcement efforts on the front end of the supply chain and link them to our public health efforts here within the United States so that we can measure our effectiveness in the only place that matters, and that is in the public health space. Because regardless of what we do in terms of law enforcement or interdictions or seizures, we cannot be successful unless we reduce the number of people who are losing their lives to these very dangerous drugs. Could I get the next slide, please? So today, I'm just going to discuss a few strategy priorities related to this webinar's topic, which is incredibly important, overdose prevention and naloxone, and it's something that we spend an enormous amount of time on here in ONDCP. The heart and the central goal of our strategy is to save American lives. And we do that by prevention, and we do it by treatment leading to long-term recovery, and by preventing the flow of illicit drugs from overseas into the United States. But we have specific efforts that are aimed at this in our strategy. So one relevant topic that we have is safer prescribing. So both the CDC guideline and the DOD VA guideline suggest co-prescribing under certain conditions, and we support following these guidelines whenever possible. In ONDCP, we have had an uncountable series of webinars, meetings, and most recently led by a detailee that we had from the Food and Drug Administration to focus specifically on co-prescription of benzodiazepines. So although, as we know, naloxone doesn't work on benzodiazepines, but the co-use of those drugs with an opioid is dangerous. And we would like to see practitioners not co-prescribe them, but if they must, to prescribe someone already on a benzodiazepine or another sedative to make sure naloxone is available for that individual. And I believe we have a speaker coming up who will address the recent FDA actions on that topic. The second thing is improving the response and monitoring of drug overdoses. Naloxone access varies widely throughout the country. Most states have standing physician's orders, and some require co-prescription. I think the most important thing first that we must do is we have to ensure that the reversal of a potentially fatal overdose is not just another event in a long and protracted struggle with addiction to dangerous drugs, but it's the first important step toward effective treatment leading to sustained recovery. A naloxone reversal shouldn't be the end of the road. It should be the beginning on a path to treatment and recovery. And we work very hard to ensure that we have programs that link people to the care that they need, which is incredibly essential. Can I get the next slide, please? So let's talk about COVID for just a moment, because I think we can all agree in this benighted year of 2020 that COVID-19 has made everything much more difficult. And that is particularly true in the area of substance use disorder and opioid use disorder. We've seen the numbers as well, and we expect that COVID will have had a significant impact on overdoses as a result of people using drugs during COVID-19. But if I had one word that I could use to describe where we've been since March, it would be solitude. And it is that particular aspect of opioid use that makes naloxone so incredibly essential. And we have got to look for those places where naloxone is not so available and make sure it gets in the hands of those who need it, because we have a heightened probability that individuals are using alone. And we know that this has been a feature of many communities in the past, and that's been one of the defining features of the opioid crisis, is that people are using much more dangerous and potent drugs like fentanyl and fentanyl analogs, and that they're using them alone. And that's what's made naloxone so incredibly important to our efforts and made it such a life-saving drug. One of the other things that we spend a long time looking at is, I don't want to call them underserved populations, but maybe unsuspected populations. And one of those includes college students. And some colleges are going back, and some may eventually come back later on in the year or come back in the spring. But we have spent a lot of time talking to college administrators and college presidents and letting them know that you don't have to have an opioid use disorder in order to suffer an opioid overdose. And that's one of the things that makes naloxone so incredibly important. We have seen, and I see this every single day, and I've seen it every single day for the last 5 years, of synthetic opioids like fentanyl and fentanyl analogs being mixed in to non-opioid drugs like methamphetamine, or in fake pills as counterfeit Xanax or counterfeit other drugs. And so individuals that don't have an opioid use disorder can overdose by opioids. And so it's incredibly important that in all those areas where that sort of drug taking is possible, that naloxone is available, because we have people who were never considered themselves to be opioid users suffering opioid overdoses. That goes for pressed pills, that goes for cocaine, methamphetamine, and a greater understanding and realization that these drugs are being mixed into existing non-opioid drugs, I think, is incredibly important. And finally, as I talked about, naloxone in the hands of the people who need it, I know we all know about our law enforcement and our first responders having ample access to that. But we also have to look at family members of individuals who have been prescribed opioids, family members of individuals that we know have opioid use disorders, because they very well may be the only person available when a person overdoses. We're in an environment now where our medical system is highly stressed. And, imagine, if you will, overly taxed ambulance services or medical services, particularly in our rural and tribal areas, makes it so much more important that an individual with naloxone be on site, because it may be that it is harder for an ambulance or a first responder to get there as quickly as maybe they have in the past. And as I said, this has been exacerbated in our rural and our tribal communities. And so I want to thank you all for allowing me to have a couple minutes with you. I'm going to stay for the entire session. So if you have any questions, please feel free to ask me at the end. But I appreciate the important work you do, and I appreciate the chance to be with you here today. So thank you so much, and back over to you, Congresswoman.
Thank you, Kemp, and thank you for your leadership, and thank you for your participation today. And we want to thank the administration for their continued dedication to addressing all components of the opioid epidemic, and in particular its overdose prevention initiatives. So to wrap up our three federal speakers for this afternoon, I'm pleased to introduce Dr. Marta Sokolowska of the FDA's Center for Drug Evaluation and Research, or CDER. Late last month, the FDA announced publication of a revised drug safety communication for naloxone, which encouraged greater dialogue between patients and providers around naloxone, both when beginning as well as renewing treatments. So within CDER, Marta serves as Associate Director for Controlled Substances, where she oversees the Controlled Substance Program. She and her colleagues pursue activities and policies to identify, mitigate, and manage emerging issues with controlled substances to minimize risks associated with problematic use while enabling appropriate access to these products for medical use. Marta is a recognized expert in drug use liability and scheduling strategies. She has facilitated numerous initiatives to improve public health by advancing the science of assessing drug abuse liability. She earned her doctorate in psychology from McMaster University in Canada. Welcome, Marta. Thanks for being here. The floor is yours.
Thank you very much for the kind introductions. And first of all, thank you very much for inviting me to speak regarding FDA actions related to addressing the opioid crisis, and specifically regarding increasing access to naloxone. So briefly, FDA has been very much involved and very much engaged in addressing the opioid crisis over the years. We have our 4 pillars, 4 key activities that we are focusing on. First and foremost, decreasing exposure to opioids, regarding particularly in case of acute opioid prescribing. We know that there are many more tablets frequently prescribed, that they are needed by patients, and also making sure that those pills who are not required, no longer required, that they do not stay in medicinal cabinets, that they are being disposed. So we are acting on both the decreasing the exposure as well as dispensing and eliminating those dispensed medications that are no longer needed. We are working on increasing availability of pain treatment that would not be associated with abuse potential, who have lower abuse potential, to helping and supporting the development of such medications, improving elimination of illicit opiates on the market. But today what I would like to talk about the most, as I mentioned, is our actions regarding increasing access to naloxone as part of supporting our patients who have developed opioid use disorder and prescribed potentially medication for opioid use disorder, as well as those who are currently being prescribed opioid medication and they have them available. So making sure that they are going to have availability to naloxone in case there is a problem that arises. So briefly, as many of you know, currently there are 3 FDA-approved forms of naloxone. The first one is the injectable one. It's the older medications that older forms that have been available for a long time. And recently we had 2 new entrants into the market, auto-injector and nasal spray medication. Naloxone formulations, those 2 formulations were designed for community use and for family members' use in case there is a need. Furthermore, as we have these medications being available on the market, we also wanted to make sure that not only that they are being available and approved, but that we provide additional support for the community to access these naloxone formulations. And in order to do so, in September of 2019, FDA has released a statement really specifying that even though prescription naloxone as a medication requires prescription, in response to the opioid crisis in most states, as well as in the District of Columbia, they have passed laws that allow pharmacies to dispense naloxone under standing orders, which replace individual prescriptions. And furthermore, in some states, pharmacists can prescribe and sell naloxone. We believe this information is very important so the patients know that there is a broader availability of naloxone, even if they don't have a prescription. Furthermore, that communication statement also highlighted that all three forms of naloxone can be utilized in community setting, both by medically trained and not medically trained persons, if there is a need to administer naloxone. Another action that I wanted to highlight is our involvement in trying to make naloxone more available by making it over the counter. So throughout the years, we have had a number of interactions with various stakeholders, particularly in December of 2018, we had two-day advisory committee meeting on strategies to increase availability of naloxone for community use. And during that meeting and other meetings, we have heard the interest, especially for harm reduction groups, to make naloxone available over the counter. However, in order to make these drugs available over the counter, they require customer-friendly drug fact labels. And we've heard from diverse stakeholders, they identified that creating these drug facts label, especially that they have to be tested in studies with consumers to show that the consumers can understand the use of these products without medical supervision, that conducting these studies can be a real roadblock for companies to bring the over-the-counter medications to market. Understanding the need to have naloxone over the counter and trying to support sponsors in bringing those to the market, FDA has conducted our own studies and created the drug facts label and created the studies with consumers and published them. So now any company who would want to bring naloxone over the counter, they'll have available that information and they will not have to repeat that work. So we are hoping that that's going to be very helpful and speed up this initiative. Furthermore, we have in April 2019 approved first generic version of naloxone nasal spray that could be used in community setting. Again, we think that's an important action. And the last but not least that I wanted to discuss today is our action from a couple of weeks ago regarding opioid products label update. That would further recommend and stress healthcare professionals considering prescribing naloxone for those who are at increased risk of opioid overdose. So as I mentioned, on July 23rd of 2020, we have released drug safety communication stressing that for all patients, we discuss the availability of naloxone and consider prescribing it to patients who are at increased risk of opioid overdose, such as patients who are using benzodiazepines or other CNS depressants. Also for people who have history of opioid use disorders or who have experienced previous opioid overdose. Furthermore, healthcare professionals should also consider prescribing naloxone if the patient has household members, including children, who could be at increased risk for accidental ingestion an opioid overdose. We have also suggested that for all patients who are prescribed medicine to treat opioid use disorders, healthcare professionals, again, should discuss the availability of naloxone with their patients and should strongly consider prescribing it. For methadone and buprenorphine-containing products, we also suggest that healthcare professionals should also consider prescribing naloxone, as patients in the household could be at increased risk of accidental ingestion of opioid overdose. And even for those who are not currently prescribed opioid pain relievers or medicines to treat opioid use disorders, but if the healthcare professionals consider that these people could be at increased risk of opioid overdose, we suggest having them to prescribe those medications as well. And with those drug safety communications, we have also required the manufacturers for all pain relievers and medications to treat opioid use disorder to add the recommendations to the product label information as well as the medication guide. So just in conclusion, I want to summarize that FDA is very much engaged and involved in trying to address the opioid crisis. There are multiple actions that we have been implementing and working on to increase access to naloxone. And as mentioned earlier, we are also very concerned regarding the impact of COVID-19 on availability of naloxone and the increased rates of opioid overdoses that become apparent from a number of anecdotal and preliminary information and data that we are obtaining. So with that, I just want to say thank you and transferring back to Congressman Cabono.
Thank you, Marta. Thank you for your remarks and for your hard work. We're definitely encouraged by the agency's efforts to improve awareness, understanding, and utilization of naloxone, particularly during this pandemic. So thank you for joining us today. So looking ahead, we'll now hear from two more individuals on the legislative and clinical efforts to further address naloxone access and availability initiatives. I know we've touched on this previously, but this session is really about underscoring the importance of overdose reversal products. Each speaker will provide a few minutes of remarks, and if time permits, we'll have a brief Q&A. To ensure we remain on schedule, we'll be saving all questions until after our presenters' remarks and initial dialogue. At any point, our viewers may submit questions to the panelists using the Q&A function on the left-hand side of your screen. We'll do our best to get through as many questions as possible and address the remainder in follow-up. So first, we're thrilled to have Representative Deborah Conroy join us today. She represents Illinois' 46th district, which is the western suburbs of Chicago. She's been serving there since 2012. She is a passionate community activist and a tireless advocate for mental health and DuPage County schools. In her time within the State Assembly, Representative Conroy has poured countless hours into her work as chair of the House Mental Health Committee, among other priorities. Before her time in the State Assembly, she was a parent to 4 DuPage County students. As a volunteer teacher, PTA member, and a nonprofit leader working to support District 205 schools. So Representative Conroy has displayed a long-standing dedication to addressing mental health and SUDs. We look forward to learning about her ongoing initiatives this afternoon related to improving naloxone access during the COVID pandemic. Representative Conroy, please proceed. Over to you.
Thank you, Mary, and thank you for that introduction. Thank you to CPAP and MAPTA for the opportunity to share a perspective from Illinois. I first took office in 2013, soon after starting a mental health committee in my district. That allowed me the opportunity to hear stories from my community of the struggles families were having. These conversations made me aware that addiction has reached into almost every family in one way or another. In 2017, I became the chair of the first mental health committee of the Illinois State Legislature. I take great pride in sharing with you that when in these unprecedented partisan times that we currently are trying to operate in, if you come into my committee, you cannot tell the difference between a Republican and a Democrat. We have had great successes in terms of moving legislation forward here in Illinois on a bipartisan basis. Then and now, we have been working to remove the stigma surrounding mental health and addiction, continually using language that begs people to embrace the fact that our brain is the most important organ in our body and therefore deserves to be treated through health care with the same respect any other part of our body does. In having a committee that focuses solely on mental health and addiction, it allows us as legislators to move these issues to the forefront. It is the goal of the committee to create a mental health and addiction healthcare system that provides a continuum of care for all. In today's unprecedented struggle against the COVID-19 virus, mental health and addiction, along with many other things that we are doing wrong in a society today, have risen to the top. With the many struggles the virus has brought to our communities and homes, it should be expected that everyone should be acutely aware of their own mental health struggles. We know that those with existing mental health and addiction issues will face life-threatening challenges. In Illinois, we are seeing a reflection of what is happening all over our country, that overdose deaths are increasing at a rapid pace. We are also seeing many of our most vulnerable community members, many of whom have lost their jobs, lost their insurance, and in some cases lost their homes, being affected at alarming rates by the inconceivable challenges of coping with the COVID-19 pandemic. Today in Illinois, our opioid death numbers as of May have doubled. In DuPage County, the second largest county in Illinois, the county where my district resides, in a 3-week period, we had 20 opioid deaths. Because of these statistics and the fact that we see no end to the virus in the near future, we know we have a crucial responsibility to provide every possible tool to save lives. In Illinois, we are fighting to be the 10th state to pass co-prescribing legislation that will require naloxone prescriptions to be prescribed with opioid prescriptions. We have a moral responsibility to acknowledge the truth we are seeing highlighted by the virus and how it has disproportionately affected our minority communities, and we must work diligently to remove stigma and provide resources and a continuum of care for healthy minds and bodies so that everyone can reach and achieve their full potential. Addiction is a disease and not a crime, and therefore needs to be treated as such. If someone has a heart attack, we use every medical resource to save their lives, and in the case of opioid addiction, we have the ability to do the same. Therefore, until co-prescribing is the law in our country, I will continue to fight in Illinois and encourage other states to do the same to make co-prescribing common practice. Thank you for this opportunity, and I'll turn it back to Congresswoman Bono.
Thank you very much for your hard work and your passion, Representative Conway. Next, I'm pleased to turn it over to Mr. Tim Fenske. He is the current president of the National Association of Boards of Pharmacy. Mr. Fenske is the pharmacy administrator at Bournewood Health Systems and the chief pharmacy officer at Sullivan's Healthcare. Further, he is recognized as a full fellow for the American College of Apothecaries and is an adjunct faculty member at both the Massachusetts College of Pharmacy and Health Sciences and also Northeastern University Bouvet College of Pharmacy and Health Sciences. Tim earned his Bachelor of Science degree in Pharmacy from Northeastern University Bouvet College of Pharmacy and Health Sciences, and he received an honorary Doctor of Pharmacy license from the Oklahoma State Board of Pharmacy. Tim, thank you very much for being here. We look forward to your remarks, and I'm pleased to turn the call over to you now.
Well, thank you very much. It's my pleasure to speak here today from a pharmacy point of view on the opioid epidemic that we're having. Just to start with some statistics, if you look since the COVID epidemic has started, we've seen an increase in overdose in March 18%, 29% in April, and 42% respectively in May from last year. And it's because of COVID and our isolation and economic disruptions and not having paycheck coming in, disruption in the drug supply chain. With that being said, only a fraction of those who need treatment for opioid use disorder are actually receiving it. Close to 21 million people aged 12 or older needed treatment for substance use disorder in 2018. And only 17.5% of them received any treatment. And in 2017, 1.7 million Americans were in need of medication-assisted treatment were unable to access this treatment. Now, just to be clear, I know we're talking about naloxone in reversal, but as one of my colleagues said earlier, treatment starts right after the overdose. So with medication-assisted treatment, we're talking about buprenorphine and naloxone, and in cases for dispensing controlled substances for initial use of detox and long-term maintenance. So although the federal government has prioritized expanding access to MAT, medication-assisted treatment to reduce OUDs and overdose barriers, there's a few things that are concerning, and pharmacists and the National Association of Boards of Pharmacy are actually trying to support. It's very rigid for provisions to get medication-assisted treatment for even any provider having to take a 8 hour or 16-hour course. The burden is on those who are eligible who actually have a DATA 2000 waiver. They have a cap on how many patients they can actually see. And excluding providers such as pharmacists really limits access. It's estimated that 3% of eligible providers that can get a DATA 2000 waiver for prescribing of medication-assisted treatment actually have it. So currently, pharmacists play a large role in just dispensing. However, given their accessibility and expertise, pharmacists can take on that role of prescribing medications. One stat that I actually did see is that most patients live 5 to 6 miles from a pharmacy. So it's that access that we're looking to actually increase. In almost every state, pharmacists are able to get into what's called a collaborative practice agreement with providers to prescribe certain medications, and there's at least 8 states that allow for that to actually prescribe controlled substances used for MAT, and they're California, Idaho, Massachusetts, Montana, New Mexico, North Carolina, Ohio, and Washington. And basically, with them having such a high access point, be able to prescribe and get them medication-assisted treatment, we could also refer them to cognitive behavioral therapies as well. Allowing pharmacists to provide MAT for patients diagnosed with OUD and allowing the control at the state levels through the boards of pharmacy would build on our recent efforts. A lot of board pharmacies have been really instrumental in guiding their licensees, meaning their pharmacists, to actually use the prescription monitoring programs that have been put in place to actually see when individuals have gotten their last prescribed medication, or even if they're naive, to actually advocate for dispensing naloxone with all high-dose medications. In 2017, more than 70,000 died from drug overdoses, which is and 68% of those deaths involved opioids. From 1996 to 2014, at least 26,000 opioid overdoses were reversed with naloxone provided by community-based organizations, not just pharmacies, but other community-based organizations like churches and local organizations. We know that naloxone access has created a 9 to 11% reduction in all opioid-related deaths. And state-approved naloxone programs prepare laypersons for emergency responders to administer naloxone to individuals who are experiencing an overdose. Now, on the right-hand side here, you can see a colleague earlier basically said the 3 different. There was the injectable, there's an auto-injectable for personal use, and the Narcan nasal sprays. Which all pharmacies in 50 states have access to prescribing with either what's called a statewide prescribing protocol or standing order. While the naloxone dispensing has increased for everyone who may need it, but they're not always receiving it. So prescribing varies across the United States based on the state laws and recommendations. But I know that my colleagues as pharmacists have been out there. They've been actually trying to give the counseling that patients need in order to have this. And we also try to make sure that people who are in the homes and the caregivers also have access to it and actually know how to administer the naloxone. Particularly important are the high-dose opioid prescriptions that we're dispensing. Patients basically, when we ask them if we can prescribe them for them, we say that we can. They basically say, no, we don't need those. And then when we really get down to the heart of it and let them know that basically you really should have it just in case, because these medications are highly potent, and basically taking double the medication could cause an overdose. And normally that's enough to get them to take the prescription from us. While naloxone dispensing by pharmacy has increased in 2012 to 2018, only one naloxone prescription for every 69 high-dose opioid prescriptions is actually prescribed. It's getting better, but we're not there yet. And as I said earlier, the lowest rates of naloxone dispensing are observed in the rural communities. Fentanyl, which has been getting into a lot of our counterfeit prescription pills and illicit street drugs, is highly, highly potent. And basically, the way that we're telling people to use naloxone now is that you may need to do this once, twice, 3 times, possibly even 4, depending on what was taken. And naloxone only lasts for about 30 to 45 minutes, but it does wear off. So again, we may need additional doses. These are steps to prevent overdose and increase naloxone access locally. I know the first 2 that I just talked about were dispensing naloxone for high-dose opioid prescriptions, counsel patients and caregivers on how to use naloxone. I know many of my colleagues are doing that right now. I do it in the hospital with my patients who are getting discharged. Everybody should really know what the naloxone access laws are in your state. Are you able to go in and just purchase it? Can you purchase it from the pharmacist? Do you need a prescription? A lot of times you can go to community organizations that actually do a training and provide free naloxone kits, but you really need to look for them. They're usually held at churches, at least in my area they are. One of the things that we're looking to do is encourage legislators and regulators to allow pharmacists for prescribing collaborative practice agreements. Most of the 50 states do have these, but they're limited based on the Board of Pharmacies and their rules and regulations and what they're allowed to do. What I'd like to do in closing is, this is Joe Adams. Joe Adams is a past president of NABP, and unfortunately, like many of us on this call, you've had a friend or an acquaintance or a family member who has been affected by this epidemic. Joe lost his son to an opioid overdose, and he basically, this is a 1-minute video of a 6-minute video that can be found out on YouTube. But this 60-minute video, 60-second video can be found at safe.pharmacy. So I'd like to play this for you. That was just a public service announcement that we put on as an association. It's been viewed a couple 100,000 times already. But again, I thank you for the opportunity to speak with you today, and look forward to the questions. Turn it back over to you, Congresswoman Bono.
Thank you, Tim. And I'd seen that video before. It's really powerful and very well done. Thank you for sharing it with us. At this point, we're going to move into our Q&A. And I'd like to start with questions for all of our panelists. And I believe Kemp is still on the line, so Kemp, please jump in if you'd like to at any point. But the first question is, what are some of the most significant challenges that you've identified to date around expanding access and utilization of naloxone? Are there key barriers that you've identified and are looking to address as part of these efforts? So any panelists want to take a crack at that?
Hey, Mary, this is Kemp, and I'll go ahead and get started. I think, believe it or not, after so many years, I think one of the barriers, and this is true when I was talking about college students, I think is awareness. I think it's the importance of making naloxone widely available and ensuring it gets in the hands of people who need it. And this is particularly folks that fall into a couple different categories. Number one, they are not opioid users or don't consider themselves to be opioid users, but they fall victim to opioid drugs being mixed into the drugs that they're using. It falls into another category, particularly in rural America. You know, I live in Fairfax County, Virginia. I could get an ambulance into my house in probably 3 minutes or so. That is not the case for the vast majority of America. And so we've got to ensure it gets in the hands of people so that they can save their lives before an ambulance or a first responder can get there. And then obviously for our tribal communities as well, the opioid crisis has landed on them in an outsized fashion. And so ensuring that they have wide opioid or naloxone access, I think is important. I think the second thing is, and this is something, and I'm not going to say this is frustrating for the federal government because this is just the way that it is, but it is, when I talk about the uneven availability of naloxone across the country, these things are governed in many cases by state laws. And we just need to understand that while we have a national vision for how available we want naloxone to be, it is up to states to implement that vision in accordance with their own laws and whether they have standing orders and things of that nature. So, and then the third one is we certainly hope that cost is not a prohibitive factor, although we know that in some cases that it is. And, you know, to the extent that we can level that out and that we can put naloxone in the hands of people that need it, whether it is a family member or whether it is someone who works in a library or it is someone with, that is routinely around people, that are opioid users or could fall victim to an opioid overdose, I think the better off we are. The final thing I would say, particularly during COVID, is that a lot of the touch points, whether it's a syringe service program or whether it's a methadone clinic, it's a treatment center, a lot of the touch points that you could have with individuals with opioid use disorder, some of them just aren't around during COVID-19 for a lot of different reasons. And so we missed the opportunity to kind of see folks where they are and make naloxone available to them. And that's something that has been made manifest during COVID. So those are the kind of the four broad categories that I would lay out, but I'd welcome any of the other panelists to chime in as well.
Well, Kemp, as a follow-up, I'm just going to read a question that came in through the website, and it touches on what you mentioned, but they're asking, this is Monica, she's asking what is the best way to bring Narcan to college campuses, particularly in the residence halls where the students are living. She has heard that the resident assistants cannot administer naloxone or touch students in the residence hall should someone be found having a drug overdose. So do you have any advice for Monica on how to get this into residence halls?
Yes, thank you. That is a superb question. So last November, we had an event here at the White House where we invited college presidents, administrators, deans of residence life, and we talked about this very issue. And there were a lot of different feelings and attitudes about it. So my first answer would be, you need to go and talk to them. And you need to, number one, you need to tell them what the threat is to their student population for opioids being mixed into non-opioid drugs. And the second thing you need to tell them is this is a life-saving medicine. Please do not be afraid that, and we have heard this from some college administrators, that it looks bad and it looks like they have a heroin or a fentanyl problem on their campus if they make this widely available. That is not the case. And so I think we need to communicate with these colleges. I think we need to also let them know about that and this was a misunderstanding, that if you administer naloxone to someone who is not undergoing an opioid overdose, you are not going to harm them. and that there are already in most states Good Samaritan and civil liability protections, even in the case that something should go wrong. And so I think that there's a little bit of fear of the college's image. I think there are liability fears, and it just comes from a general misunderstanding of what naloxone is and how it works. And I absolutely agree. My son went to Hampden-Sydney College. He was a resident advisor for 3 years, never touched naloxone a day in his life. And he had so many students, who he had to take care of when they'd had too much alcohol, too much to drink, having emotional issues. And it just stuck in my mind. It was just amazing to me that every resident advisor should have it on hand and be trained how to administer naloxone, and that colleges should not be afraid of having it on their campuses. They should be more afraid of not having it on their campuses. That's the clearest thing I could say to colleges across the country who don't make it available.
Thank you, Kemp. And I have a question for Marta. How does the FDA plan to help educate prescribers on the need to co-prescribe based upon the drug safety communication?
So thank you for the question. So we are currently trying to, first of all, by updating the labels. We think that this is very important. This is our communication platform with the prescribers. So we'll be asking the manufacturer of both opioid pain relievers as well as opioid disorder medication to include the information regarding the conversation that we strongly recommend them having with their patients. So that is our key platform for including that information. We also have REMS that include information, but our key communication platform is the labels at this point.
Thank you. And Kemp spoke about the importance of the state's role. So for Representative Conray, what comes next in Illinois? How are you working with your fellow legislators to advance these efforts and ensure naloxone and other overdose reversal products are able to make it into the hands of those who need it?
Well, Mary, what I would tell you is that in Illinois, we continue to fight this fight. We have a resolution over veto session because we had such a truncated spring session. It was difficult to get the bill through. Obviously, we didn't have the opportunity to do that. So we are bringing forth a resolution over veto session, and one of the first things we plan to get on the docket for January is going to be passing the co-prescribing bill. We feel very strongly. We have in Illinois done a pretty good job of expanding access to naloxone, and we feel this is the next step that we need to take. And, in the process, also continue to have the conversations about removing stigma around mental health and addiction. And what we've seen in Illinois, that we've seen in other states and around our country, is we have such a responsibility to get into our minority communities and to continue this conversation and do everything we can to prevent overdose deaths in those communities.
Thank you. I don't know if you dropped off or ended abruptly there, but I think that what you all are doing is fantastic in that it could be precedent-setting. But do you have some advice for how other states might find support for introduction of a co-prescribing bill? What steps should they do?
What I would say, Mary, to that is that the most powerful thing I think we've done in Illinois, honestly, is to have a legislative committee that is focused on mental health and addiction. It's allowed us to have a platform for these conversations. And when we first started this committee, people told me I was crazy and there was no money. And I said, yes, I am crazy, and I know there's no money. But when we get to that point, we have to educate people as to what the needs are. And that's what we've done here. And I believe that's a powerful thing for every state to do, is to develop a legislative foundation to start having these conversations and educating people on both sides of the aisle. Like I said earlier, you cannot tell a Republican from a Democrat, because these are issues that we've spent the time educating legislators on, and it affects everybody regardless of what side of the aisle you sit on.
That's always encouraging to hear. Thank you. And I know we've got time for one last question, and I'm going to toss this to Tim. Are there efforts underway to help improve prescribing and getting naloxone out there via pharmacies. Clearly, everybody keeps mentioning education and awareness. But what are the efforts that are currently underway? And we're about out of time, so Tim, if you can be somewhat quick with your response, I'd appreciate it.
I'll try to be very quick on this. So basically, the standing order or collaborative practice agreements are the ways that pharmacists are able to give naloxone out. And by being able to have a standing order and be able to prescribe it, we're able to actually put it through insurances. So people shouldn't be afraid. If they have insurance, they should be able to get. I know our Medicaid system allows us to dispense to them as well. So those are the main two ways that pharmacies are actually getting naloxone out there. Other than the FDA, God bless you, that you're going to try to make it go OTC. That's the best way because the stigma out there, nobody wants to come up to the pharmacist and really ask for it.
Thank you. Hopefully that stigma is something that a lot of us with CPOP and MAPTA have been working on for years. I know a lot of you have been as well. Sad to think that it still exists, especially with such a great life-saving medication like naloxone. But at this point, I'm going to try to wrap things up, and I want to thank you all for participating. A special thank you to our speakers who have joined us today as we've talked about accessibility and utilization of overdose reversal medications such as naloxone during the COVID-19 pandemic. We hope you found the exchange useful as we consider the implications of the pandemic on addressing the potentially fatal consequences associated with opioid use disorders and overdose. I know that we have a handful of questions that we didn't get to, but hopefully we can follow up with each of you and get you some answers. So we want you to know that a recording of today's webinar will be made available to all registrants and posted to both the CPOP and MAPTA websites. If you have not done so yet, we'd like to encourage everyone to register for the final webinar that will be focused on addressing excess medications in the home, where we are all homebound and kind of tired of being there. But in any event, there's tons of excess medications, and we'd like to talk about the importance of getting rid of them. So that will be held next Monday, August 17th at 3 o'clock. We hope that you will be able to join. So should there be any further questions or follow-up to this webinar, please contact Matthew Rubin. Once again, thank you all for caring so much and for your leadership and all you're doing, whether you're a presenter or just a participant on the line. Thank you for your leadership and your hard work with this opioid epidemic. We thank you for joining us today, and we hope to gather with you again on the 17th. Thank you very much.
Great. Thank you.